All right, welcome back, everyone. We are going ahead and we are going to go ahead and get started here. We've had a very in-depth and thought-provoking morning, and looking forward to having this incredible panel join us to discuss the current state of the healthcare system. What we're doing today is we're going to be utilizing our 5 points of healthcare framework, which takes a look at patients, payers, providers, purchasers, and policymakers. And we're going to have a conversation about the current state of incentives, how they work, including the barriers or limitations of the current structure, and introduce work that is being done to address or work around those barriers. As always, use the Q&A function in the Zoom chat link. If you have any questions, feel free to reach out to any one of us at Cambia Grove. Nick at cambiagrove.com is a good person to reach out to if you have technical difficulties. And we are really looking forward to getting this conversation started. I'm going to go ahead and exit the stage and welcome Kim Pendergrass to the stage to kick us off. Kim?
Thank you so much, Maura. I really appreciate the opportunity to be here today. I'm Kim Prendergast. I am the Director of Social Determinants of Health for Community Care Cooperative. We are in Medicaid ACO in Massachusetts, and I am really excited to be moderating this session. We have a great group of panelists. For those of you who were just on the last session, you heard Dorothy talking about being in the same boat and rowing in the same direction. So welcome to our boat. We have our 5 panelists. I'm really excited to hear those different perspectives. So I'm going to invite my panelists to turn on their videos, and we will do some introductions. And then we're going to talk today about what incentives are working to drive towards better health, what are the barriers, and then how can we make things better. So we'll hear just an introduction from each of the panelists, and then we'll go around and start our conversation. So Karen Johnson, why don't we start with you, if you want to introduce yourself.
Hi, Kim. Thank you. And good morning, everyone. I'm Karen Johnson. I am the Director of Performance Improvement and Innovation at the Washington Health Alliance. For those of you not familiar with us, we are a purchaser-led multi-stakeholder organization that actually represents all of the 5 points that you see here in the Zoom room that we're in today. And so I have the good fortune of having been there just a little bit over a year. I work with our Quality Improvement Committee, which represents our clinical leaders. I also have the privilege of working with our Purchaser Affinity Group, which is a great fit for today's conversation, and my role as the purchaser sort of point, and consistent with work that I've done over the 30 plus years prior to joining the Alliance, which was largely concentrated as a benefits consultant and broker. So work with a lot of purchasers over the years. Thank you, Kim.
Great, welcome, Karen. All right, our next panelist, I'd like to have Peter introduce yourself, please.
Thanks so much, Kim. I'm Peter McClung. I'm Vice President of Client Management and Account Management at Regence Blue Shield. So my primary role is to manage our team that interacts with the acquisition of new employers or purchasers. And we have about just over 13,000 of those purchasers within our system, and that represents about 1.3 million members in Washington. So I'm really pleased to be on the panel today as one of the points.
Welcome. All right, our next panelist is Sophia Tripoli. Sophia, why don't you introduce yourself next?
Hi, everybody. Thank you so much, Kim. My name is Sophia Tripoli. I'm the Director of Healthcare Innovation at Families USA. Families USA is a nonpartisan consumer advocacy organization working to ensure that every living person has access to the highest quality, most affordable and equitable healthcare and good health that they deserve. I lead much of our work under our healthcare value pillar, so do an enormous amount of work around incentives, both good and bad, and really looking forward to the conversation with all of you today. Thank you for having me.
Great, welcome. All right, next, our provider perspective for today, Arlesia, why don't you introduce yourself?
Good morning, everyone. My name is Arlesia Bailey, and I serve as the Senior Director of Community Health and Development at the Odessa Brown Children's Clinic, which is the only primary care clinic of Seattle Children's Hospital. I'm here and I am representing the provider perspective, probably at the broadest level. I just want to emphasize that I am not a physician, though I play one at home with my own children. So really glad to be here with you all today.
Wonderful. Welcome, Arlicia. And our patient perspective, we have Michael Middleman. Michael, why don't you introduce yourself?
Hi there. Good afternoon or good morning, everybody. I'm joining from the East Coast, so representing Philly kind of strong here. Hopefully you all know what's behind me in that picture. So I represent, yes, patient perspective. Currently, I'm the board president and founder also of an organization called the American Living Organ Donor Fund. It works with living donors across the 50 U.S. states and the U.S. territories. Board member of an organization called the Light Collective, which focuses on digital patient rights. But I think most importantly, from the patient perspective, I'm just recently 40 years old, so I'm not thrilled about that part, but my journey started a very long time ago in the early 80s. So I am a multi-chronic condition patient, so multiple diagnoses, and started with a rare disease very early on, like I said, in the early 80s at pediatric institutions. So a safety net hospital, two much larger academic institutions, and then obviously all the way through college, adolescence, et cetera, teenage, and into adulthood and into the adult world hospitals now. And I've kidney disease is the main perspective, transplant, end-stage kidney disease. That's mainly where I live. Some of my other chronic conditions are more neurologic in nature, and some of them are range, I guess I like to say, from the more mundane, but for other people they are not more mundane, right? Just for me, that's sort of where they hit. They are all sort of immune related. But I've been in the commercial world from the health plan perspective as a patient, also professionally. I am also a dual eligible, so I've been on Medicare commercially and at the same time for a patient. And then I've also been on Medicaid at points. So I come from a lot of different perspectives. And I look forward to helping and seeing how everybody can share and work together. And I also am a cybersecurity researcher, important to understand.
Wonderful. Welcome to you all. And I invite you all to take a look at everyone's bios. We introduced each of the panelists, but they all bring such a wealth of expertise to this panel. So take a look at their bios when you have a chance as well. So what we'll do here is I am going to ask a variety of questions over the next about 35-40 minutes. Please use the question and answer box to ask your questions, and we will incorporate those and then really open it up for questions the last about 15 minutes of our time together today. So I'm going to kick this off first by asking each of the panelists to talk a little bit from their points perspective. What incentives drive towards better health? So what's working in our current state right now? I'm going to start with Arlicia and do the provider perspective, and then go to Mike, and then we'll get to the payer purchaser and the policy perspective. So Arlicia, what's working for the providers right now in terms of incentives?
Well, I think that, Kim, great question. I think incentives that link the promotion of, or lead to the promotion of healthy individuals and healthy communities really lend itself toward what many providers jump into healthcare for in the very beginning. So just getting back to what some of us refer to as the basics, really offering quality care to those around us is really where we see the benefit of an incentive program. Let's focus on, for example, production and really focus on outcomes.
All right, Mike, I'll turn that question to you. From the patient perspective, what's working in terms of incentives that drive towards better health?
This is a fascinating question. I want to say there's not a lot actually that seems to be working right now. You have to understand, I guess, for those of us that live multiple decades with different diagnoses, right? It's a constant battle to to sort of understand what incentives exist, and if we're fighting multiple diseases, particularly my underlying disease is a rare kidney disease, right? That's sort of when things flare, when they come back, if you have recurrences. So it's not really a straight line, right? I have been a very expensive patient to the health system throughout almost 4 decades. I was trying to add it up recently. Just I got lost very quickly, let's just say, in the numbers. Well, just transplant alone, right? Kidney transplant. I've had multiple transplants over the years. So just transplant alone, you're looking at a couple $100,000, and from 100,000 to 200,000, sometimes more, depending on that. But there are a lot of things. Right now, Medicare is really taking an active role. So I happen to be lucky at the moment and be a primary Medicare patient, but really Medicare seems to be taking the lead with some of its innovation models. And there's a big focus on kidney patients right now. So I don't know if I would say it's working yet, but there is a focus on us and sort of kidney health, which I think is a real positive at the moment.
Okay. It sounds like for you, the ability to move between some of the different payer models. You said you're dual eligible, you'd been on Medicaid in the past. So let's turn that question to Peter. With the payer perspective, Peter, what's working for payers in the current state of incentives?
So when incentives drive to better health, I think that's like the crux of the issue. And I think Bob and Dorothy talked about this a little bit in the prior session, is that the current construct of what I'd call the system hasn't historically been driven by health in a sense, or wellness, or it's uncompensated in a sense within that existing construct. And so as the system starts to connect with those, and those that are funding the system starts to connect with better health, things that have actually worked are basically having someone know you as a patient within the system. So efforts around medical home, or organizing data specifically to making sure that somebody has a baseline on you within the system, and then knows when there's variance in health and can steer and direct and move with along. And the more that's integrated and data is integrated with that, it has been proven to show better health in a sense, because you're integrating in components of health or prevention or engagement in behavioral lifestyle changes that actually changes the dynamic of your health. I would say the work that Bob and Dorothy also referenced around not just wellness, but more behavior change and the focus on metabolic syndrome within the last several years as a compilation of health issues that can be directed, addressed, and incentivized has improved the connection between an employer workplace and connection with health. Because as they mentioned, payer, like as a representative of a payer, it can get muddled and confused quickly, because we not only represent 65% of the marketplace that is privately funded, but the vast majority of that is through employers. And in fact, vast majority of those employers, 70% of them, are now self-funded. So they, in a sense, pay the bills, and we organize the administration of the payment of those bills within that system. So getting alignment amongst all those constituents is tricky.
Thanks, Peter. Karen, let's turn this to you. From the purchaser perspective, talk a little bit about what you see as driving towards better health right now and incentives that are working.
Yeah, so I think purchasers are really in a unique position to sort of advance health, because they really are concerned about the health and well-being of their workforce. I do think that the business model in which purchasers operate that Peter was getting at just there is so complex, and I've heard it all the way throughout. And I just want to say also, just really quickly, let's acknowledge that our patient voice is a really, really informed patient voice in our conversation today. And there are very few Michael Middlemans out there who really understand not only what it means to be a patient with complex needs, but also how the system, the small s system works, because I do think all of those are really, really meaningful issues. But I think we've hit on some things that as purchasers, We have levers within our control to incentivize health, and one of those is incentivizing healthy behaviors. That is something we always want to focus on in a workforce setting. What we do know, though, also is that there are exorbitant costs associated with health conditions that have nothing to do with behaviors and are just bad luck or circumstance. And those situations that drive a lot of our costs, and there was a chat message from one of our someone in the audience saying that they had $2.4 million in Medicare expense last year. That is not, sadly, unusual to hear about costs for individuals that are in the multi-millions of dollars in a single year. And it's hard to fathom how you spend that. And I think it's farther more difficult to fathom how you spend that when so much of that information about spending, which I'm sure we're going to get to, is not really what's working. But I think an opportunity to sort of think about some of the rest of the conversation is, what are the incentives for how many of the incentives are hidden from view? I think that's an important consideration. And I would say our incentive is to, as purchasers, is to unveil as many of those hidden incentives as we possibly can.
Thank you, Karen. All right, I'm going to turn this question to Sophia. And Sophia, I'm going to ask you to also talk about, from a policy perspective, what's really helping to get us towards better health, and then shift the conversation a little bit for us to what's detracting and why are those detractors there from a policy perspective? And then we can then really get into the nitty-gritty of this conversation.
Thank you, Kim. And that's a perfect tee up, because that's where I was hoping you were going to encourage me to go. But I really agree with everything that the panelists have said so far. And Mike, your initial reaction of like, not much is working is kind of where like my head was going initially, which is like, we know what can work and we have a sense of what is starting to work. But we haven't really made that transition in terms of full redesign and creating new incentives that we know are going to get us to things that make the difference in people's health and wellness, like incentivizing primary care, incentivizing behavioral health, making sure that we have integrated systems of care, making sure that patients and consumers have access to the types of providers when they need them, they know how to access them, that we are incorporating their patient-reported experiences and outcomes into incentives and into how payments are flowing through the healthcare system. We know that those things can work, and we've started to see some progress, but we certainly have a lot more work to do to, I think, be in a place where we say, like, we really have a good set of incentives that's working. I think the set of incentives that we see right now are sort of existing, sort of underlying economic sort of we often call like distortions in how healthcare payment is designed and how healthcare delivery is designed that really incentivize sort of the status quo of business interests rather than the interests of the patient, of the person, of the consumer, who really needs to be at the center of the healthcare payment and delivery enterprise, so that we can actually drive health improvements and improve their quality of care and their health overall. And then we see sort of this other bucket that's around these new financial incentives, these new sort of payment incentives that are largely coming obviously out of a lot of different sectors, but somebody mentioned Medicare and the Innovation Center and new delivery system payment reforms. But a lot of those incentives are built on the broken infrastructure, the broken incentives around, fee-for-service payment and, a dynamic where reimbursement is based on sort of a business transaction, a very transactional interaction between a provider and a patient, rather than on, am I keeping my patient healthy? Am I getting them what they need? Are they improving, day to day, month to month, year to year, and whatever their health needs are? So hopefully that will get a little bit of the controversial conversation going, but I'll pause there and let others jump in too.
All right, I'm going to invite Peter to jump in here. So from the, respond to Sophia from a payer perspective.
Yeah, so from a payer perspective, payers, like I said before, a minority of the population actually participates in sort of an insurer-paid environment, in that the vast majority is actually through self-insured employers or plan sponsors, both governmental and commercial. And so it's tricky because the those purchasers haven't aligned their expectations in how they purchase healthcare for employees. So if you look at like the acquisition of a customer in that sense, in my environment, we're still judged based on the fee-for-service system and the ability to provide a discount on services. It's very difficult with all these new payment arrangements for there to be judgment and values assigned to it for these purchasers in a comparative way amongst the system. The other thing is because the system was built on what I'll call sick care, right? Or return to normal, or payment for intervention at the time of illness. There is very little payment structure outside of these new models for the maintenance of health or for a continuation of health. That's within the medical construct. And so there's, if you were to, because these purchasers are valuing price, I think in the last session, they talked more about how the purchasing community hasn't been able to align and provide the greatest depth of individuals or market share in order to drive those expectations from the market. So the work that the Alliance is doing is great, but we want to encourage purchasers to move more in that direction and have those expectations when they actually make the purchase for healthcare.
All right, Karen.
Yeah, it sounds like that got teed up for me pretty nicely.
Yes, it does.
Thank you, Peter. I think we could not agree more with what Peter is saying in terms of pointing out the challenge. And I'll be really interested to hear from Arlicia about this from her perspective, because I do think that so much of what we're talking about, it happens both inside and outside of care settings, but we're spending our money in care settings today. So that's what tends to get our attention. And I think what we're mostly talking about today is how do we create better aligned incentives in the care delivery system that achieve better health. I think that we completely agree that there are way too many payer-specific or purchaser-specific expectations of how care should be delivered around either just something as simple as what measures are you using to value success, what are you covering, what are you not covering, what requires prior auth, what doesn't require prior auth. I mean, just the level of variation in coverage and approach to delivery of that coverage in a care setting creates complexities on the delivery side of the system that are really just untenable. And if you think about the graphs that we've all seen that show the growth in healthcare spending and look at how much of that increased spending is going to administration versus clinicians delivering care, you have sort of your answer for what's working and what's not. I mean, it's clearly we're spending a lot on not on care, but on the administration of care. And so I think that is really at the crux of the business model, the sort of if we want to get back to basics of delivering care, we've got to build a business model around it that works better. And I do think that given we're multi-stakeholder at the Alliance, we hear from all perspectives, but we are purchaser-led. And I will say that we have a lot of conversations with them about the need to align with payers to deliver, to create new payment models and ways of measuring success that are wholly different than what we have today. And I think currently we have a little bit of this going on. Who's going to go first? Is it the payer? Is it the plan? Is it the payers working with Medicare? Because Medicare is driving some change, as Mike pointed out right out the top of this. But who we've got to all start pushing in the same direction. And I think that is going to take breaking down some of the barriers that I see alluded to in one of the questions, which is, I'm sure we'll get to this idea that there are way too many hands in the healthcare cookie jar at some point in our conversation today.
Yes. Arlicia, so what does this do for providers when we have, as Bill mentioned earlier, nobody has enough market share to say this is how it's going to go. So as a provider, you're looking at Peter's requirements and Karen's requirements, and what does that mean at the end of the day for the way that the provider is actually providing patient care, and what's harder as a result?
Yeah, great question and great conversations. I think that for one thing, is there's a lack of continuity in the delivery of care for sure. But I think what providers are left with is recognizing that we just need to deconstruct the business of healthcare. It is a broken system. I couldn't agree more with what Sophia has presented. I think what's missing often is that there's a lack of understanding of communities. There's a lack of understanding of what is available in communities to support patients and families beyond the scope of the four walls of a healthcare system. If I don't have access to healthy food, if I don't have access to green spaces, if I can't get care in a way that I want it, in a way that respects my cultural being, it is a broken system. It's just this repetitive cycle where we're all, again, pointing fingers at one another. And I think we need to rebuild it in such a way that really honors what the expertise of those who are seeking the care, the consumer, the patient.
Thanks, Alicia. Okay, Michael, I'm going to ask you, I'm going to pull in a question here from the chat for a minute. So want to hear your thoughts on this, the misalignment as a patient. And then if you can bring in your thoughts on, as Peter mentioned before, wellness is uncompensated. So if we're looking to shift from sick care to well care as a patient, what's exciting to you about that? And what's hard in the current model that's going to be difficult to get us there in this return to health kind of system?
Yeah, man, those are very challenging questions. So I'm listening right to what everybody has to say. I think I'll take the first part of your second part of your question first, right? So as you think about the well care perspective of things, right? I think that I continue to see the challenges in specifically what some of you have mentioned to the well care shift, which is, first it's the profit in healthcare, right? Which I'm not opposed to people making a profit, right? But when I look at hospital systems and payers interacting with each other, there's a constant bickering over contracting rates, right? So you see, all of a sudden you'll be a patient and you'll want to go to your hospital system, and maybe you want to get your preventative care, right? But now all of a sudden your patient, you can't go because they're out of network all of a sudden, right? So as we shift from being patients in different types of care settings, from pediatric, teenage, adult, right, college years, geriatric, you shift plans over time, right? So the challenge with a well care system is that your benefits are changing all the time. So now if you're at a self-insured employer, your benefits may become one thing, but your out of pocket has shifted, right? So if you're at a company that's not providing insurance through a self-insured coverage type of situation, and you have to pay for your policy through another perspective, then it may be, you have to go to the gym to get some type of well care setting, right? Or well care incentive, right? Or if you have to do this type of activity, what if it's not really feasible for somebody, right? And these are some of the bigger challenges as you shift from one to another. All of your benefits are constantly changing. In addition to that, right, you have to look at what I think is a big preventative, in that it really depends on who your health insurer is contracting with. And it goes back to that hospital side, but now I look at it from the provider side let's take the kidney market, for example, right? It's just the fact that I have to say the kidney market is kind of intense and a little bonkers in my mind. But there have been incentives now for people to try to keep people from going to transplant or getting end stage kidney disease, right? Keep you in that CKD area, right? Don't let you get to stage 4. Don't let you get to stage 5. But it's really almost dependent on, for me now, if you want to stay in that wellness space, I'm CKD T3, right? Transplant stage 3. And this is, the technical sort of nomenclature of where I sit as a patient. So let's keep me from going to stage 4 and stage 5. Challenge being, what if there's this cool new startup, they're private equity backed, they have to turn a profit, they have to raise more and more money, and now they're not contracted with my insurance company. What if I wanted to be a part of that program? Well, I can't, right? What if I wanted to be a part of that program and I was, and then I went to another insurance company? So I think these are some of the things that we have to think about. In addition to some of the Medicare programs that were mentioned, digital health can really be an opportunity to take this on. But as we get there, thinking about the data agency that we have, I think, as patients, and I use those terms very specifically, can really help push us forward to a well-care environment. So I'll give one more example of, look at what happened with One Medical and Iora Health, which was just in the news right now. One Medical is a primary provider, right? They're buying another type of provider to take care of another type of patient, but the CMMI kidney care type of incentives and the new models that are out there sort of keep you with your nephrologist, and they don't put you with a primary care provider. So that doesn't line up for somebody like me. So I'm almost, if when I try to help patients, you have to try to think of everybody's perspective individually. And it really becomes an extreme challenge to try to be preventative, right, and stay in that wellness space.
Thanks, Michael. I want to take this back to a comment that Karen made a minute ago about the hidden incentives. And maybe Karen and then Peter, can you talk a little bit about what you see as some of the hidden incentives that make it difficult for us to move towards better alignment?
Well, how much time do we have? I think healthcare in so many ways is a black box. First of all, clinically, we're counting on experts in care delivery to hopefully make decisions with us as patients when we do need care, to make the right decisions. And there's a lot that we need to learn about that at the point of care and how we can do that better. But if you're talking about the macro system, which is sort of where our conversation is going toward, and how it sort of drives the incentives across different organizations, there's just no other market that I'm aware of where the person who receives the service has no visibility, is operating without information as to the cost or quality of that service that they are seeking and or receiving, and ultimately does not pay for the service or the care that they ultimately receive. So there's a lot to unpack there. I mean, there's the need for individuals, the folks that we advocate for as purchasers. There's a strong need for them to get better information. And in the absence of information in healthcare, we tend to bring sort of the same sort of consumer behaviors that we do in a lot of places, which is more is better and higher cost is equated with higher quality. And we know those things are not true in healthcare, but we can't unpack that for individuals until we sort of open up the black box, which is how much do things really cost? And then who's paying for that? So those create incentives too. And I would say that a significant breakdown, and all we have to really do is to look at the recent Haven experiment with Amazon and Berkshire Hathaway and Chase. Yes. So Sophia's going to say it for me. But, I think if you look at sort of the debrief on that, it's pretty much clear that maybe an employer-sponsored sort of approach isn't the best approach unless we begin to do it differently. And with some construct and some guidance that I think if you go back to the ACA and the essential health benefits and some of the market corrections that were created that we now take for granted, is there an opportunity for another huge step in that? Or do we just need a totally new construct? I think there is, though, I think I've lost even the thread of your original question, Kim. I apologize to all of those people listening to this. But I think that, in terms of the patient and the incentives, how can you say there are any? Because we operate as individuals in the healthcare system with complete lack of information.
All right, we have a couple of questions here that I want to take us on this idea of somebody has to be the first mover. And so as we're considering what's difficult here, So one question is, Medicare is often said to be the first mover of healthcare. So to what extent so Peter, I'll tee this up for you first. What extent do you follow what Medicare does? And what extent do you feel like payers can take a stand as a first mover to try to align your incentives a little bit differently?
Yeah, so it's a great question. What Medicare has at CMS is that market presence. In a sense, if you think about the market and how they can, and also the dictate power, in a sense, of setting price or setting policy for this large portion of the market. So naturally, it is easiest to implement market change and connect a lot of these incentives with the consumer, which I agree with Karen. There's a near complete disconnect between the consumer, the person that's consuming healthcare, and the financials associated with it or the funding. And in markets where that is taking place, like let's say like LASIK surgery or whatever, we start to see more market norms of alignment of lowering cost over time and that kind of thing. But back to Medicare and CMS, it's a great place to start because of the market presence that they have. So it's easier to fold in line with that. As the payer community has gotten in front of that, it becomes more difficult because of some of these hidden incentives I referenced earlier, like those that purchase through are self-funded, let's say, measure exclusively on the old fee-for-service system, a discount when they're in how they're selecting care, almost exclusively. So it's if you get too far ahead, you end up looking less competitive in that scenario, and thereby would lose customers or lose effect in the marketplace. So yes, it's easier to loop into CMS and kind of go. The provider community is already acquiescing to that. And then move forward. Also, when we look at what's happening in Washington State with state government as well, and the pushing forward of governmental agencies into these particular realms, like with the Healthcare Authority and/or expansion into rural areas with different style plans, and moving more of the market. It does create new opportunities for insurers to align with those and serve the consumer better.
Alicia, let's turn this back to you for a minute to think about any other hidden incentives that you are feeling the burden of as a provider. And then maybe we can turn a little bit toward thinking about some of the measures. I think as we talk about what are some of the measures that we need to align on to allow providers, to allow payers to work a little bit more in concert as we think about incentives.
Well, what I'll say, Kim, is less about a hidden incentives, but more about aspirational incentives that I think we'd like to see is, looking for opportunities to actually incentivize the consumer communities would be an interesting approach to consider, coupled with, again, just greater transparency and less complex language about what it is, what's happening as part of the patient's healthcare experience. As it relates to, what was the second part of your question, Kim? I'm sorry, I missed it.
I've heard a lot, but both the last panel and here, we keep alluding to some of the common metrics. So especially as we're asking providers to measure so many different utilization and key performance indicators, what's making your role more difficult because of different incentives from different perspectives?
I think the challenge is a lack of agreement on what those performance metrics should be, and perhaps different insurers wanting different things. So I think that just the incongruence of that sometimes makes things a bit more difficult from the provider perspective. And I'm speaking mainly on performance metrics.
Okay. Sophia, I'm going to turn it back to you. One of the other things that we're seeing here in the thread that I want to touch upon is as we try to shift the incentives there are going to be winners and losers. There's a change in power that has to happen. So where does the power go if we want to drive towards a better state of health? From a policy perspective, where do you think we need to put our policy agenda to drive the power to the right place?
Yeah, it's a great question. And I mean, I think like any economist will tell you there are winners and losers, regardless of what sector you're working in. And I think that's probably true. But I think, you know, I'll take a little bit of a less pessimistic view and just and say, like, I think part of what we need to do is you know, the reality is that we have a for-profit healthcare system, and profit is generated based on service interaction, the delivery of individual services. It's not generated based on keeping somebody healthy. I think like fundamentally that point right there is that generate revenue in the healthcare system, fine, but generate it because you've kept somebody healthy, you've kept them out of the emergency room, you've gotten them in to see their primary care doc, you've actually, you know, you've controlled their cardiovascular disease, you've controlled their diabetes effectively, and you've ensured that they have, you know, stable housing, food security, right? Like all the things in a person's life that impact their health, make it profitable, allow entities, plans, providers, others to generate revenue based on those basic tenets of keeping somebody healthy. Now, that's a great concept. It's very difficult to do. Obviously, that's part of what the transformation movement is about redesigning those incentives. What are the right measures that we can put in place to allow that to happen? But I think fundamentally, in terms of your question about power, I think it's a shift in power, not taking power away, but empowering patients and consumers more, putting patients, you know, we talk a lot about patient-centered care, yet the interests of consumers, of patients, are very rarely represented up in the Hill, where, you know, Families USA, we spend a lot of our time in Congress and working with the administration of, you know, both sides of the aisle, right? And you think about consumer incentives, and they're often the last interest represented up on the Hill. It's because the healthcare, there's a lot of money and power in the healthcare lobbying institutions who are pushing, you know, very specific policy agendas to preserve the status quo of the incentives in the healthcare system. And so I think what it takes is providing a counterbalance to those interests. And I think, you know, some of that work is already happening. Families works on this regard, where you're bringing together groups with aligned interests, consumers and consumer advocates, patient advocates, with employers and purchasers, with labor unions, with primary care, right, where we have very aligned interests, and we're providing an alternate way to think about designing incentives that meets the needs of people rather than only meeting the needs of the business interests of the healthcare sector. So I really do think that's what it takes. I know there was a question in here, somebody said, like, is there interest from policymakers? I think it was specifically about primary care first, but broadly, I'll just say, like, I think there is interest from policymakers. They, especially given the impacts of COVID-19, what we've learned about the healthcare system, the impact that it's had on certain populations, you know, Black, Latinx, Indigenous communities having such significantly higher rates of infection and death, you know, they're paying attention, and there is an interest in understanding how do we move forward. And so it takes work, and there's a lot of politics involved, but I do think that there is interest to figure out how do we sort of push ourselves past this sort of status quo, this sort of stalemate that we've gotten ourselves into around the effort to transform away from sort of a volume-based high, you know, sick care system and more towards wellness and health and improved financial incentives that incentivize actual health and wellness.
Yeah, Kim, I'm gonna chime in here a second, and I know I'm not prompted at the moment to say something, you know, but I think there are a couple of things that I'm hearing, and you know, one of them I'm consistently challenged when I hear this in situations is sort of the consumer mindset, right? So healthcare being really the only industry I think that doesn't take too much of feedback into perspective, right? There are some metrics, right, around patient experience, things of this nature that take into account, right? When you think about payers, they're looking at sort of patient member experience, right? They do a lot of work on member experience and the digital component of that. How do you feel about interacting with us, right? But ultimately, this idea about handing the health system over to the consumer, well, the biggest challenges are and why the One Medicals and the Ioras are making billions right now in sort of growth stocks and growth companies is that we don't really use it until we need it, right? This is the always end all challenge with healthcare, right? So, shoot, I wouldn't be using all of this health services if I didn't need it, right? I really never had a choice from the time I was a little kid, right? So but you have to contrast somebody like me versus somebody maybe who like Peter or Alicia, who I'm just using you two as an example because you're here on the panel, maybe come down with some kind of genetic disposition they never knew they had, but manifests later in life, right? Or they come down with diabetes, which then leads to chronic kidney disease or something, use as an example. And then you kind of have to figure out, how do you navigate this system, right? And so we continue to see people want to use broad spectrum data analytics across the board, right, to try to solve this problem and incentivize better care to patients. So let's try to identify people earlier, right, becomes an issue. Across the board, whether it's hospital systems, right, striking deals with Google, et cetera, mining our data, or insurance companies, which have been doing it for a while. I think ultimately, if we want to shift it and make more incentive to the patient, the regular person out there, there needs to be some sort of, I'm going to say it again, like data agency, right? And I think somebody put in the chat earlier, right? We are probably sitting in the greatest this time period where the wealth divide is going to increase drastically based off of access to data and usage of somebody's data, right? And so incentivizing a patient or a person to have better health care while their data is continually being used to make money or to target them in a different capacity completely changes and flips the system around what we're thinking about and what we're talking about right now, right? Which is deconstructing the system a bit, but the patient still doesn't have data agency and still doesn't have rights and still then can't choose where they want to go. So until we break down a lot of the silos that exist between all these different providers and people that are servicing you in one way or another as a patient, or as you may be experiencing that as a care partner for somebody, like my mom did when she had ovarian cancer, right? That was a whole different experience for our family, so I think these are the big challenges kind of facing us today, and data agency, digital rights being a huge component behind that. And maybe can help us with some of these inequities that are out there, giving people some agency to take care of what's theirs, but also take care of themselves, right, and empower them. I know that maybe was not the question that was being asked, but it kind of builds a bit on what you all are saying.
That was absolutely perfect. Karen, I saw you take yourself off mute. Do you have a comment you want to chime in with?
Well, I think there's a real tension that I think purchasers have weighed in on as it relates to how individuals navigate the healthcare system, which was inherent in both what Sophia was saying about what's a better business construct to, align providers' interests, the delivery system interests with health outcomes for individuals, which translates into populations when you look at it sort of as a whole. And then a desire for individuals to have, freedom to choose. Where do I get my care? And Michael's taking it to a really, important level of, I am also my data as it relates to its use in the healthcare system and its movement across the healthcare system. And there's a lot around that. But if you just back it up to a really, really simple sort of terms that we all understand today, employers and most of the even federal programs are essentially what we call preferred provider organizations, or PPOs, which means I get to choose where I get my care. And even though there are some certainly important in-network and out-of-network considerations, and the out-of-network considerations we've talked a lot about as surprise billing, and I think there's a lot of really good, important work happening to address that. The reality is, especially in Washington state, the majority of the PPO networks that individuals select into most frequently are very large. And I can kind of go wherever I want, whenever I want. And I think as consumers, we think that's what we want. But I think the question this conversation begs is that really serving the best needs of patients? Because we have so little information to sort of pick off the list, where is the right place to go for care? So you have that sort of desire from a consumer, individual, accessing care perspective. And the tension that creates then when we talk about the business model is, how do you then take these people who move freely across lots of providers and then sort of pin the accountability for health on one provider or one provider group or one provider system, if I have the ability to go in and out of that system of care? And so it's a real challenge that is present, I think, in the design of plans. I think Peter has made some really excellent points about the variation in coverage and approach that trickles down into different measures and different payment models, not so much different payment models today, because most of it's still fee for service, but measures that are tied to right now pretty fundamentally small pieces of payment that go to providers, but take an extraordinary amount of time to execute the administration around. So we've got this sort of inherent tension that we don't talk about that much, but we really, it's coming, it will come to bear. I think if we can wrap our minds around that, how do we as individuals retain the freedom that we want and still get the care we say we want? We've solved the problem, and you can close your conference, but I don't think we've solved that. I think that's a very, very, very difficult question. And one that purchasers are sitting at the seat around in terms of, they're designing the coverage that creates whatever consumer incentives there are around where to get your care and how to get it. They've got a significant hand in creating those incentives. And I think it's a really important conversation.
Thank you, Karen.
So I'm going to chime in again and just add something too, because I was talking with a patient today who's on dialysis, right? And take it as an example where they're not on Medicare, but they're on commercial coverage. Okay, so they're in that coordination period, right? For those of you out there in the audience listening, not everybody who's on dialysis is on Medicare, right? And if they are, it's not always paying first. Okay, these are the other kind of challenges. This person was messaging me bills today, and I was saying, what are those bills that you're getting? And they have employer-sponsored health insurance, right? From a pretty good policy, actually, if I don't say so myself. It's a good one, if there is such a thing, right? So in this sense, though, it turns out the dialysis provider is out of network. But how was the patient supposed to know that? And because it's where they were getting dialysis, and then they changed to another employer, and now they're getting all these bills. And so does the patient now in this sense have a choice? Should they all of a sudden up and change where maybe they like the nurses, maybe like the staff, the techs, everything is being provided in the right way? Maybe the experience is great, but now it becomes an affordability challenge and an incentivization problem, right? So the insurance company isn't saying to the patient, you could go here and you could be this much money, right? And the patient is kind of figuring this out on their own and now has to think, what now, right?
So this is a great lead into a question that's here. So I'm going to read this and I'm going to toss this to Arlesia for a minute, because I think it's exactly what you're getting at, Mike. So do any of the panelists, so I want to have Arlesia respond first and then anyone else can jump in, agree that the direction we should head here is to deconstruct the status quo by repositioning physicians at the seat at the table. So let's give the provider organizations the responsibility for total cost of care. We're moving towards value-based as opposed to fee-for-service, so that they can direct patients to the most cost-effective and clinically appropriate setting. And then I'll just toss into that, if it makes sense, to think about some of these other investments in the community and social determinants of health as well. So Arlesia, do you agree? And then what would be the most difficult about that?
Well, I think from a provider's perspective, I don't want to have to worry about any of those details. All I want to worry about is making sure that my patient has the best experience, best possible outcomes that I can contribute to. I don't want to have to worry about all those other details. That is sort of my end game, ensuring that not only my individual patient has all that they need, but I'm also contributing to healthier communities. And there's a lot of different ways that I can do it, but I think we go back to the business of healthcare is not set up in such a way to support that model. But I think that is ultimately what the provider wants. Oftentimes when patients come in, providers don't even know the details of what insurance pays for what. All they're thinking about is taking care of that patient that's right there in front of them and ensuring that they have the best possible outcome.
I would jump in here too. I agree in that that sentiment has driven a lot of acquisition into integrated healthcare systems of independent providers, because it's placing too much on the provider to say, steer your patient to the most effective need or provider within a particular space of what they need at the moment. But by having these integrated systems, that then compensation can run around the integrated system, it mirrors and becomes the closest to like the group health or Kaiser model that was mentioned earlier. Is this idea that let physicians do what they need to do. Now, these integrated health systems do create an incentive, like a steerage incentive, right? Which this system has been very hesitant to move towards because of the backlash in the 90s to managed care, and the idea that having somebody know who you are within the health system actually is better for you. But how do I get you to engage with that person or that provider in the system that's going to be the center, and make sure they know what's happening with you?
Thank you, Peter. All right, in the interest of time, we have 3 minutes left, and I am going to ask you each to wave a magic wand. And if you could change one thing to improve our incentives, what would that be? So I am going to start with Karen, and then I'm going to go to Sophia after that. So Karen, take it away.
I'm torn between two, really. This is like a Sophie's choice here to pick one. I'm going to say get rid of the black box and propriety and the for-profit orientation of healthcare. But getting rid of the black box will help, regardless of the underlying incentives. Get rid of the black box, put it out in the open, cost and quality and everything else.
Yeah, I'm going to have to go with that. I mean, I think there's so many things you could say here and it's hard to pick one, but I think unleashing the underlying price of healthcare to the public, to researchers, to policymakers, and corresponding quality information alongside that. I think, and there's already efforts underway, regulations that are being implemented right now, hospital price transparency that are moving in that direction, but unleashing price and quality so that we can actually know what the heck what is the actual underlying price of a healthcare service, and why does it differ so much from market to market? And even within an existing market, why it varies so much from one hospital to the other hospital, a mile down the road from each other, and understanding, well, what is the quality associated with that price? I think those two pieces of information together would really unleash a much needed transformation and attention of policymakers to really drive some important change.
Thank you, Sophia. All right, Peter, you're waving a magic wand.
I would connect data in an interoperable way, which is already being worked on, right? In order to create actionable items that are instructed or instructive in order to do what's next in healthcare for you personally. So regardless of where you go, that all your data is either centralized with you as the consumer or with your person that you know in the healthcare system, whether you call that a primary care, medical home, whatever, if that data is aligned so that everybody knows what's happening with you and then direct your next step.
All right, Alicia.
Yeah, I would deconstruct the entire thing. I would decide, this is Alicia, not my agency speaking, I would deconstruct the entire thing. I would de-silo it and look at how just what we've done today with all of these perspectives, and look at how we can really incorporate that into a new vision of healthcare, like health wellness for all of us. I'd also look at some of the existing primary care medical home models. There's so much good work that's happened or has the potential to continue to happen through those models, and looking at how we can do that on a broader scale.
All right, Michael, you get the last word because this is our patient-centered new incentive state. What is the magic wand that the patients wave to move us towards a healthier state?
I mean, do I get a magic wand that makes 3 magic wands? Where's Harry Potter's things when you need them? No, I would say that I can't boil it down to one. My apologies, but I think some of what each of you said is very important. I think the top 3 maybe, right, is just get rid of profits, please, in healthcare, right? Like, just get rid of it, and private equity. Like, I'm sorry, as long as private equity and healthcare for-profit entities are making decisions around who can receive what type of care, then that's always going to be a challenge, right? Who gets what for free, who doesn't get what for free, et cetera. And just provide care, right? So you didn't see kidney care companies grow until Medicare Advantage decided that they would take care of kidney patients, and then private equity had to be convinced, right? So there's a reason for that, right? So one, try to drive away some of that, right? I'm not saying we can get rid of all of it. The interoperability component will be huge, and obviously it's already happening. But along with that, I would be remiss to point out, as a cybersecurity person, let's make sure that we protect patient data, right? Ransomware is a major problem. I can tell you most of the tech platforms out there and the digital health startups are extremely hackable and not private and are not secure, even though they will claim to be, right? I can most likely give me a team and we'll hack into them, okay? And we'll show you how data agency becomes really important. So interoperability, great. Data agency is a must. And so don't use my data without me being able to be a part of that, right? It goes back to one of the ultimate patient advocacy sayings we have for years, and we owe it to generations before: nothing about me without me, right? It goes back to that. So let's and obviously, I don't think also the last component is, silos are bad, but let's try to keep people a little bit where they belong sometimes, right? Not everybody needs to be involved in everything along the way, and I think that becomes a big challenge.
All right, Mike is frozen, but I want to say a big thank you to all of our panelists. This was terrific. So such rich conversation. We could go on for hours. So I'll turn it back over to Maura. I know you're going to have an opportunity to speak to each of these panelists during the breakout rooms. So a big thank you to all of you. And Maura, I'll turn it back over to you.
Yes, thank you. Thank you to everyone. And Kim, a huge thank you to you for moderating this. We have done this multiple times, the 5 Points panel, and my colleagues were texting back and forth. We don't know how we're going to replicate anything close to the robust conversation that we just had. You all are fantastic, and thank you for being willing to join us for this amount of time. You can go ahead and shut your videos off while I give a couple of instructions on what is coming up next. Okay, so we're going to take a quick lunch break for those of us on the West Coast. It's 12:34 right now, as my computer shows. When we come back at 1 o'clock, we are going to have opportunities for everyone to join a breakout session. Each of the points of each of these 5 points will be hosting this breakout session. And this is where you can come in and have a dialogue and get your questions answered. join the rooms where you can get answers to your most pressing questions. We are going to have 2 back-to-back sessions. So you'll join the first one at 1 o'clock, and then we'll have a great discussion. And then we'll close out that session and then have a second session at 1:45. After each of the sessions, or after those 2 sessions, we will reconvene as an entire group to have a couple of takeaway discussions with the 5 points panel, all of the 5 points, to have a closing discussion for today. So again, attendee guide, use that to get your links. If you have any questions, please let us know. Otherwise, we look forward to seeing you in a breakout session of your choosing at 1 o'clock. All right, thank you all.